Hi everyone, a very good evening and I welcome you all back to the very exciting series which is Labs to Clinics, from taking microbiology to medicine and onto the patient's bedside, right? So in the first episode we had talked about fever with rash in a patient and how to approach such a patient in your clinics. Today we are going to discuss a scenario of an acute gastroenteritis outbreak in hostel of an MBBS college, right? So those of you who have joined, please come and say a hi. Good evening, faculty, and others who are joining in. I guess we can we can play games later, but I think let's attend the lecture right now. Those who have joined, please come and say a hi, because the more interactive we can keep the session, the better it is. Because that is how. Good evening, Zerin. Good evening. All right, guys. So, I will be discussing two interesting cases today. One is a case of welcome freshers, rather happening in your hostel right now. Well, Manish, then I think you can learn something from here, and probably this session will also help you unlock the mystery of what is actually going on in your hostel. So case one is welcome freshers, a rather horrifying welcome that the freshers got, and the case two is the bloody horror of two final year students, right? So two different type of presentations of an acute diarrheal or acute gastrointestinal illness, and how you are going to approach both the different scenarios, because not every diarrhea needs a metronidazole and a norfloxacin combination drug. Not every diarrhea needs antibiotics, and not every diarrhea is supposed to be ignored, because that can also be fatal, right? Okay, so Manish, even if they are not testing the water quality, then you must probably approach the authorities that, okay, probably water testing is not what is needed. There can be other causes of the gastroenteritis also. Right, great. So let's start with first an orientation towards diarrheal illnesses and gastrointestinal illnesses. You all are aware that there are the different terms. So what is diarrhea? Diarrhea particularly means that the frequency and consistency of the stool changes. That's it. So WHO says that the changed consistency of stool or increased frequency than what is normal for that person. So there is no cutoff which we can say that, okay, more than 2 stools is diarrhea or more than 3 stools is diarrhea. There is no exact number which is a cutoff. However, some institutes in some countries do consider more than 3 stools per day as diarrhea. But then what is normal for frequency for a person? If it increases suddenly and the consistency changes, that is what we call as diarrhea. Then when it is associated with blood and mucus in stool, we call that dysentery. If it is associated with a history of travel, history of eating outside food, trying new cuisines, etc., and primarily associated with lots of vomiting, that is usually traveler's diarrhea. Then persistent or chronic we call when it is after 14 days. So whenever it is more than 2 weeks or after 14 days of continuous diarrheal episodes every day by the person, we call that persistent diarrhea. And persistent and diarrhea, chronic causes are usually because of parasitic illnesses. So parasitic diarrheas usually lead to prolonged kind of diarrheas, right? Then gastroenteritis. Gastroenteritis. Itis means inflammation. Gastro means stomach. Entero means intestine. So inflammation of the stomach or intestine, inflammation of the stomach as well as intestine. So either both can be involved, or therein the people who don't get diarrhea easily actually probably have very good hygiene practices. Okay. So, and then finally it is food poisoning. So, usually in our lives we interchangeably use the two terms gastroenteritis and food poisoning. And the two cases that I have today are going to deal with acute gastroenteritis and food poisoning separately. So, now for any gastroenteritis to be food poisoning, an association with food is necessary. Okay, if there is no association with ingestion of food, then it can be simple gastroenteritis because of other infectious causes which have no relation with food intake. Okay, so for feco-oral ingestion. Food intake is not necessary. Like somebody was saying in the chat box that we have asked the college authorities to test the water supply. So in case the water supply is contaminated, in case you went swimming in a lake and you ingested some water over there, other causes are, other non-infectious causes are also there. Then, because of fecal contamination of your caretaker, your cooks, people who are close contacts in the family, your partners and spouses, they can all become causes of contracting, gastrointestinal infectious diseases. So whenever it is right after consumption of food, we call that food poisoning, right? So two such cases we will see today. That's the difference we needed to understand. Then other gastrointestinal infective syndromes, such as acute vomiting, that is also part of the GIT, but only vomiting is happening. Necrotizing enterocolitis or necrotizing enteritis means necrosis is now happening, means dying of the tissues of the intestine, usually happens with anaerobic infections such as Clostridium perfringens, which causes gangrene in whichever tissue it goes. So even if it goes to your gut along with the food that you eat, it can lead to necrosis and death of the tissues of the gut as well, leading to necrotizing enteritis. Then pseudomembranous enterocolitis means inflammation of the colon and a pseudomembrane formation. So the very, very famous one which causes antibiotic associated diarrheas also, Clostridium difficile, Clostridioides difficile, which is the correct name now, the changed correct terminology. Clostridioides difficile is a very important cause of pseudomembranous enterocolitis. Then peptic ulcer disease, you must have heard of this peptic ulcer disease. Symptoms of food poisoning, we will come on to it. Facty, you need to wait for a minute. Then peptic ulcer disease, the very, very famous helicopter bacteria, the Helicobacter pylori, right? Why do we call it Helicobacter? My students would know this is an internal thing that we say, that just like the wings of a helicopter on the top, the Helicobacter also have the Lophotyphus flagella, right? Okay, we are not deviating. So peptic ulcer disease because of Helicobacter pylori, and infections other than GI structures such as appendicitis, other surgical causes, etc. Right? So you have whenever or every time you get a patient of diarrhea, you have to consider associated symptoms, you have to consider history of food intake or travel, and you also have to consider any surgical abnormalities which might be leading to this situation, and which is the non-infectious causes. People, Heliobacter, people thought it was stress. Sometimes it is, right? Okay, let's go ahead. Let's talk about the first case scenario. Welcome freshers. So basically in a medical college, there was a group of friendly freshers, friendly seniors who decided to throw a freshers party for the incoming batch. But by around 1 AM after that party, chaos broke out in the hostel as nearly 50 students suddenly developed profuse nausea, explosive vomiting and severe abdominal cramps. The situation escalated when the newly elected crowned freshers queen, Miss Priya, collapsed due to dehydration, presenting with tachycardia, cold clammy skin and generalized weakness. What does it look like to you? So what is your impression from this? Can I have some answers in the chat box? What is your impression from this history? So basically what are we understanding? That there is a group of students who collected together in a place. It was a party, okay, which was thrown, and after that a whole lot of them fell sick because it seems that it was a generally friendly group of seniors. So basically and also the one particular case out of all of these children, while the others were simply presenting with nausea, vomiting and cramps, abdominal cramps, one particular child fell more sick. You know, she succumbed to the illness a lot more, leading to dehydration, tachycardia, cold clammy skin and generalized weakness. So this the cold clammy skin, weakness, confusion, they are all signs of dehydration only, right? So she must have been taken to the emergency department. Now you are saying it can be food poisoning. Yes, it could be food poisoning because there is a party involved. So probably everybody ate a common source of food. So the impression it looks like to me, also you can see the major signs and symptoms: nausea, vomiting and cramps. Okay, there is not any significant diarrhea history. So whenever, and it is fast acting. So party must have gotten over by whatever time, in around 1 a.m. Immediately within 1 hour or 2 hours of the party, they have started developing the symptoms which are more or pointing towards gastroenteritis or poisoning kind of symptoms as compared to pure diarrheal disease, because nobody is complaining of diarrhea here. They are majorly talking about nausea and vomiting, except one person who, because of profuse vomiting and excessive vomiting, succumbed to dehydration. So the impression correctly, yes, looks like okay, it could be some kind of a food poisoning. So what is the first important question that you are going to ask these group of students? Chat box, guys, what is the first important question that you want to elicit from this history that you want to ask these set of students? First important question. So if you want to find out if food poisoning could be a cause, then you need to find the common dietary source. Was there any common dietary source? Was there any common dietary source? Was there any particular food item which everybody ate? Yes, which everybody ate. So when we probed further, we found out that the freshers queen was made to cut a cake at the end of the ceremony. Okay, she had cut a cake at the end of the ceremony which everybody had eaten. So you can probably think as an outbreak investigator that probably it was this cake which everybody had eaten, and the girl who was probably fed large amounts of it because she was crowned the Miss Freshers, she succumbed the most to the illness. So when we have to talk about food poisoning, what is the most common cause of acute gastroenteritis outbreak? We realize that it is an outbreak, yes, because a large group of people in a single cohort geographical location have presented with the same signs and symptoms, and the source also seems to be the same one particular thing. So definitely it's an outbreak. It is gastroenteritis for sure, because the symptoms are pointing towards involvement of the GIT, and of course it is acute because suddenly explosive vomiting and so many people have gotten it. So what are the most common causes? Whenever you come across such a condition where a huge number of people present with acute gastroenteritis symptoms, then the most common things amongst adults that you think of is actually viral illnesses, viral diseases, out of which you know that in the developing world, because there is not so much vaccination which is given, rotavirus remains quite an important thing. And actually in adults, norovirus is more important than rotavirus. So while rotavirus is more important in infants, right, but still you cannot rule out the possibility of a rotavirus infection in adults completely. However, most commonly rotavirus infants, and it is the norovirus which is associated with adult diarrhea, that too outbreaks kind of situations. Norovirus also leads to what we call as winter flu. Sometimes they say ki whenever you get, if you walk out in the cold without a sweater, you get diarrheas. What is that? That is not because the cold does not induce diarrheas. Usually in the winter season, the spread of norovirus increases. So winter season diarrheas is usually because of norovirus. Then of course, the second thing you will think of is bacterial food poisoning. Bacterial food poisoning. So now over here, this does not look like much of a case of a seasonal flu. This looks more of a case of a bacterial food poisoning, right? So what are the other important questions you want to ask? Always you want to ask the onset of symptoms. You see here the onset of symptoms is acute. It is acute, and we can see that it has happened within 1 hour. Within 1 hour of ingestion. Within 1 hour of ingestion. So the first most important question that we have asked is whether there is any association with food intake. The answer we got is yes. Right? Diarrhea. What about diarrhea? Was there any diarrhea present and absent? Some people are saying that they have mild diarrhea associated. Some are saying that they don't have. Causes of bloody vomiting, Kriti, you can very well refer to a whole range of organisms, especially most important being your hematemesis is usually caused, hemoptysis which can look like hematemesis caused by Klebsiella, but that is not the purview of this lecture. Right, fever. Was any fever associated? Why do you think this question is important? Why do you want to ask about fever? A patient of gastroenteritis presenting with fever, not presenting with fever, is it a question to be ignored? If a person with gastroenteritis is telling you that they have high grade fever or they have fever, absolutely, are you going to ignore it as a passing symptom or you're going to pay attention? Can I get some responses in the chat box? Are you going to pay attention to the fever along with gastroenteritis? So I will tell you that this is a very, very important symptom that you have to pay attention to. Why? What is fever signifying? Chat box, guys. It would be nice if we could get some queries related to the topic or some participation related to the topic in the chat box. You know, it would be nice if we could get some topic related responses. Fine, no problem. So fever, why is it important? Because now we understand that probably the cause is now have become invasive, because every time we get fever is when we are suspecting bloodstream involvement. So probably the infectious agent has invaded the intestine and it is leading to, probably reached the blood and could be causing bacteremia in this situation. So fever is very important to elicit any invasive causes, okay? And you then know that the patient is now sick. It is not a normal thing now. So my students are telling me that no, none of them have any fever. So this is very, very important for me over here, that in bacterial food poisoning without a fever, acute onset within 1 hour, now my DDs become narrower and narrower. Episodes, how many episodes of vomiting are there? 10 plus. 10 plus episodes have happened up till dawn. So lots of profuse vomiting. Other associated symptoms. So of course, some people are saying that they are feeling weak, they are feeling dizzy. Some the queen also presented with confusion. So signs of dehydration are definitely there. Was there a common source? Yes, it seems that the cake, the celebratory cake seems to be a common source. So cake, okay. Any history of antibiotic use? No, since it is such an acute episode and the entire hostel got it, so nobody decided to take any antibiotics. And also a history of antibiotic use, we need to talk about prolonged antibiotic use for the antibiotic associated diarrhea by Clostridioides difficile. So this history is not even relevant over here. Now what do you want to understand from this cake? We will just find out. On examination, the general appearance and vital signs is very, very important for every patient of acute gastroenteritis, right? So is the person looking sick or is the person looking fine? This is very important. So out of these 50 students, around 10-15 were looking fine, but our poor bichara freshers queen, she was completely sick and devastated. So vital signs, what all do you think we want to notice? The pulse, blood pressure, then what are the other important vital signs? Respiratory rate. What else? Mental status. Yes, the general physical examination. In the general physical examination, you will talk about orientation to time, place and person, pulse, BP, respiratory rate, then urine output to see the signs of dehydration. So for some people, you have to rule out hypotension, cold clammy skin, signs of dehydration. This is very, very important. Very, very important. Urine output, etc. Like I said, important signs of dehydration. On abdominal examination, why is abdominal examination important here? To rule out surgical causes, appendicitis, etc. So on abdominal examination, I am saying that okay, they were tender abdomens, but no guarding, no signs of guarding, etc. was there. Also, 50 students together cannot be presenting with appendicitis or any surgical causes. But it becomes important when you have individual standalone cases, right? So after finding out all of this, let's go back and revise our causes of food poisoning. So what is food poisoning? Illness acquired through consumption of food or drink contaminated with microorganisms or their toxins. This is extremely important, right? So over here in such an acute history, do we want to think about a complete organism sitting in the gut, or we want to think about something which is faster acting, right? Toxins, it usually results in common source outbreaks. So don't you think all of this is fitting in our case today? Yes, there is consumption of food, There is illness acquired after consumption of food. There is a common source which is there, right? And it is also time specific, time sensitive. So the incubation period, depending upon the incubation period, you have different causes of bacterial food poisoning. So food poisoning can either be bacterial, it can be fungal, such as mycotoxicosis. You must have heard of aflatoxins, etc. after ingestion of ground nuts. Now, while that is very, very specific and usually leads due to adulteration of large producers of food items, individual outbreak cases because of specific cooked food items is we majorly always think about bacterial causes. So, since these bacterial food poisoning causes are also time specific. So, within 1 to 6 hours, we remember that there were only two guys which were of importance, Staph aureus and Bacillus cereus. Staph aureus and Bacillus cereus. We know that Staph aureus is because of ham, cheese, poultry, basically milk products. And can you see here what is written? Cream pastries. Don't you think this cake was the culprit? The cake with the cheese, with the cream must have been harboring the Staph aureus. But let's look ahead. We should never be biased in our diagnosis. Do you think Bacillus cereus, specifically called as reheated fried rice syndrome? Because Bacillus cereus produces two types of toxins, emetic toxin and diarrheogenic toxin. So basically your diseases which happen within 1 to 6 hours, they are because of preformed toxins. Preformed toxins. Basically the bacteria is sitting in the food item and it has already secreted or released the exotoxin in the food itself. And then when you're eating the toxin along with the food. So directly the toxin is going in your gut along with the food. It is not that the bacteria is going and sitting, multiplying, then releasing the toxin. No, the toxin itself you have ingested along with the food. That is why the incubation period is so small, because the time required for multiplication, growth and production of toxin is all happened outside in the food item itself. Right. So the emetic type of toxin which is released by Bacillus cereus is a preformed toxin. Therefore, reheated fried rice syndrome, main symptom is going to be nausea and vomiting. Right. Staph aureus food poisoning, main symptom is going to be nausea, vomiting. There may or may not be diarrheas associated with them. Some people may have diarrhea, some people may not present with diarrheas. What about 8 to 16 hours? Even though this is not relevant to our case, but let's anyways revise, because Bacillus cereus comes here also. This is the diarrheogenic toxin which is produced by Bacillus cereus, and this is not a preformed toxin. This is the toxin which is produced inside the gut. When the Bacillus cereus goes inside the gut, then it starts to produce, and the source is also different. Here you majorly have your cereals and beans which are implicated. Then Clostridium perfringens, the guy who causes necrotizing enterocolitis also, but before it can go on to cause necrotizing enterocolitis, it will cause limited kind of a infection which is simply diarrhea. Vomiting is extremely rare over here. Why? Because it all depends upon the toxin that they are producing, right? So the toxin produced by Staph aureus and Bacillus cereus, the emetic toxin, and can you tell me in the chat box the toxin of Staph aureus? The toxin of Staph aureus? The enterotoxin which is produced by Staph aureus, which is a type of a super antigen, also, right? This is a this goes and attacks the vagus nerve, so it activates the vagal center in the brain, so it activates the vomiting center in the brain. That is why major symptomatology is vomiting, which was the case in our patients also. Then for the diseases which are more than 16 hours, so if you have eaten something day before and after 2 days you fall sick, then you are probably dealing with enterotoxigenic E. coli, Salmonella, Campylobacter, Shigella, Vibrio parahemolyticus and Vibrio cholerae. Now Vibrio cholerae will be associated with the rice watery diarrhea. This is very, very specific, and this is very, very deadly and dangerous. So putting Vibrio cholera simply as a food poisoning agent is not correct, because it can lead to a range of infections from food poisoning to fatal, severe, deadly diarrheas and dehydration, right? Then of course Shigella, Campylobacter, Vibrio parahemolyticus and enterohemorrhagic E. coli. Can you tell me what are these all causes of dysentery and bloody diarrheas, right? So they are going to lead to blood in stool production. So whenever you get blood in stool, you have to think about enterohemorrhagic E. coli, Shigella, Campylobacter and Vibrio parahemolyticus, the other Vibrio. So based on all of this, is kind of looks like Staphylococcus aureus food poisoning to me, right? So we have to understand what all types of toxins are produced by these bacteria. These toxins of gastroenteritis are usually your exotoxins, and my students would know the very famous mnemonic of exotoxin. Have you seen the movie Avatar? They are the blue colored people with poisonous arrows, right? That is what is exotoxin. Your gram positive bacteria produce these arrows or missiles which they shoot outside, and they have very high specific targets, a very exact very strong aim. So tissue specificity is seen with these exotoxins. So the ones which attack the gut are the enterotoxins, the ones which attack the particular cells are cytotoxins, and the ones which attack the nerves are the neurotoxins. So any these three type of toxins can be produced, right? And enterotoxin is going to lead to outpouring of electrolytes. So what is enterotoxin going to lead to? Watery diarrheas, profuse watery diarrheas. What about cytotoxins? They will disrupt the intestinal epithelium. So you will see inflammatory cells in the stool, you will see WBCs in the stool, you can also see the dysentery can happen, then your inflammation, enterocolitis, necrotizing kind of a disease can happen. Neurotoxins will be going to cause intoxications and vomiting. So you can see that Staph aureus, Bacillus cereus, both of the guys which were producing fast acting toxins were both leading to neurotoxins as well, right? So this is a exhaustive long list of agents, but more or less you do remember that the agents of dysentery you have to remember, then the agents of vagus nerve stimulation you have to remember, rest all will more or less cause your watery diarrheas only, right? Over here, can you tell me what is the treatment you would like to give? So now we have been able to say that we have been able to solve the case that our students was a case of staphylococcal food poisoning, right? What treatment are you going to give? What treatment are you going to give? So what treatment are you going to give to the sick patients? The sick patient are Fresher's Queen. And what treatment are you going to give to other normal or patients with mild disease? Patients with normal or mild disease. So of course, you know, nothing, simply oral rehydration. Oral rehydration is what is needed. Okay, no antibiotics. No antibiotics need to be given in these cases. So that is the dictum with most acute gastroenteritis diseases, because most gastroenteritis that you will come across in your life is either going to be viral or toxin mediated food poisoning. Now please understand, it is a toxin which has been released in the food itself. There is no bacteria actively multiplying in your gut. So how is antibiotic going to help in this situation? It is not going to help at all, because an antibiotic kills a bacteria. What is present here? Simply the toxin is present here. Toxin which was already pre-released in the food by the bacteria. So now you just have to wait for the toxin to get washed out of the body, right? There is no bacteria sitting there whom we want to attack with the antibiotics. So all of these acute gastroenteritis and acute food poisoning cases do not need antibiotics unless there is profuse dysentery or blood in stool, inflammation, fever and invasive kind of a presentation that the patient is showing you, right? So let's quickly move to the next case, which is a case of bloody horror of two final year students, right? So what is the case? Basically, there was a boy A who was a final year student. presented with high grade fever. Guys, so now here fever has come in the picture. Cramping abdominal pain is there and frequent passage of watery stools progressing to bloody mucoid stools. What are we dealing with here? We are dealing with a case of dysentery. We are dealing with a case of dysentery. 8 to 10 episodes per day. Very, very frequent episodes. After 2 days, his roommate was also admitted in emergency with similar symptoms. Right? So, all the important buzzwords is what I am telling you. What is your impression? Impression is definitely, dysentery has happened. Now, I want to know whether this is a bacillary dysentery or it is amoebic. Remember, entamoeba histolytica. I want to know the two things. Now, this 8 to 10 episodes per day is kind of pointing towards bacillary dysentery to me. Another very important pointer here for bacillary is his roommate is also getting admitted. So, the patient has been able to pass the disease very, very fast and quickly. Right, for the patient to have been excreting the cyst of entamoeba and giving disease to the roommate, it should have taken some time. Then the first important question that I want to ask in such a case, for the cases of dysentery, what is the first important question you want to ask? Food intake. Again, you want to ask history of travel, history of food intake, right? Why? All the causes of dysentery, come on. There is amoebic dysentery. For that, there is going to be copious amounts of foul smelling stool. So, you have to ask that, right? Then you have to ask travel. Why? Enterotoxigenic E. coli, enterohemorrhagic E. coli, which can also lead to traveler's diarrhea. History of food intake, Vibrio parahemolyticus, shellfish ingestion, seafood ingestion. Then your Shigella, etc. Majorly salads, history of intake of salads. So, what did the guy told me? The boy told me that the boy A was on a diet and he was ingesting lots and lots of salads. Salad ingestion was involved. There is no history of travel involved. And for amoebic, I had to ask the question whether the stool was copious, foul smelling, etc. Okay, but we can still not rule out anything. So, what do we need to do? You see, in this case, in case 1, we did not even go on to do a laboratory diagnosis. Okay, we did not even go on to do a laboratory diagnosis. You think laboratory diagnosis is needed in staphylococcal food poisoning? No, it's a self-limiting toxin-mediated disease. Collecting stool samples of 50 students, sending to a lab, waiting for the result to come, very, very problematic. What could have we done? If at all there was any food item left, that is the cake if it was left, that could have been sent for culture and diagnosis in the lab, where they could have tested, done the culturing from the food specimen, and if Staph aureus would have grown, then further that could have been sent for a PCR or toxin production detection. But that is extremely expensive and a useless kind of an exercise. So, you really need not go for any lab diagnosis. So, whenever you have acute food poisoning gastroenteritis because of preformed toxins such as Bacillus cereus or Staph aureus, you do not need to go for lab diagnosis. Whenever you have acute gastroenteritis, which is seasonal, most common Norovirus, you don't need to go for lab diagnosis because specific antibiotic therapy is not needed. So, anyways, you are only going to give oral rehydration and support to the patient, right? Or if there is dehydration, you are going to correct the dehydration. What about in this case? In this case, whenever there is dysentery, you need to give specific treatment. So, like I said, if there is any danger signs such as blood in stool and fever in the patient, then lab diagnosis becomes extremely important because now you need to give specific antibiotic therapy to these patients, right? So, over here, let's go and other questions we have to ask. Onset of symptoms, was it slowly progressing? Was it acute onset? Over here, I can see that it is an acute onset. Diarrhea is there, yes, and there is of course bloody diarrhea which is associated. Fever, yes, there is fever. How many episodes? 8 to 10. So we know that it is profuse. Other associated symptoms, of course, there is abdominal cramps, there is fever, and there is sick looking patient. The patient is sick. History of food intake, yes, we have just seen. Any history of antibiotic use, not relevant, not very, very important. So I can definitely rule out antibiotic associated. In fact, I don't need to rule out antibiotic associated ever. I just need to always ask this, because Clostridioides difficile is the most commonly missed cause of diarrhea. In the patients who are already admitted in the hospitals, who are already taking lots of antibiotics, when they develop the diarrhea, we make the mistake of giving them more antibiotics to control the diarrhea. Instead of sending to the lab for detection of Clostridioides difficile and thinking that probably this is in fact an antibiotic induced diarrhea or a Clostridioides difficile induced diarrhea, we just want to symptomatically treat the patient. That is where we go wrong. So every time a patient of acute diarrhea, we should definitely ask any history of antibiotic use, prolonged antibiotic use, right? So all of this is pointing towards dysentery to me. So this is simply a flow which is telling me diarrhea, nausea, vomiting, duration of symptoms I have seen, severity I have seen that this is severe, epidemiological features, travel, diet, exposure, etc. I have seen. So now my I should be really worried, because now the roommate has also gotten. So is it community acquired or travelers? Is it nosocomial? No, this is not nosocomial. Is it persistent? No, this is not persistent also. So all the causes of persistent diarrhea, which are majorly or parasitic causes such as Giardia, Cryptosporidium, etc., especially in immunocompromised patients such as HIV positive patient, nephrotic syndrome, steroid therapy, chemotherapy, cancer patients, in them persistent diarrhea is usually seen because of your parasites. That gets ruled out. Nosocomial means hospital stay, means antibiotic use, means Clostridioides difficile, that also gets ruled out. So basically this is a community acquired or traveler's diarrhea. Is it watery? Is it fever with blood? It is fever with blood in stool. So now you need to do the cultures and lab diagnosis. So what are your disease now becoming? Shigella, Campylobacter, your Entamoeba histolytica, and your enterohemorrhagic E. coli. Very important, right? So what is the diagnostic approach? We have just seen, whenever you have a patient of acute gastroenteritis, you ask whether patient is it an outbreak or not. Okay, here. The first question that you ask is whether it is an outbreak or not. If it is an outbreak, you go to case scenario number 1, either viral or food poisoning, right? If it is not an outbreak, then you come to case scenario number 2, where you ask whether it is persistent, whether it is nosocomial, whether it is community acquired. Over here it is community acquired. Then any sign of inflammation, invasion or sepsis. After you have come on to that, right? So let's make this flow chart. First you ask whether it is an outbreak. Yes. If it is yes, you go on to either viral or you go on to food poisoning. If the answer is no, you ask 3 questions. Community acquired, okay, hospital acquired, or is the patient immunocompromised? Immunocompromised, meaning is it persistent diarrhea? Is it persistent diarrhea? Okay, then you go on to the respective algorithm. If it is community acquired, you ask if it is watery, or you ask if there is any fever plus blood, right? And immunocompromised you have seen. These are the 3 most important questions that you will always ask your patient of acute gastroenteritis. Is it an outbreak? Is it community acquired, hospital acquired, immunocompromised? These are the most important questions that you will ask. So we are now over here in this spectrum of our illnesses. So let's look at the different causes. If it is acute watery diarrhea, you know it's just going to be loose stools, mucus may not be present. If it is dysentery, there is gross blood and mucus, and when you will, there might also be tenesmus associated, meaning pain during defecation might be associated in these patients. Then yeah, I have actually just talked about it. 14 days is persistent diarrhea. I just told you. You can take a screenshot of this table if you would like. This is simply summing up everything that I have just told you, right? Then we understand that why is this blood and mucus and fever happening? We want to see if any inflammation or invasion is happening in the intestine or not. So if it is simple non-inflammatory diarrhea, means toxin mediated diarrhea, which we have talked about. Over there in the stool microscopy, you will see no leukocytes, no WBCs or cells will be found. If it is an inflammatory diarrhea, means it is now leading to some kind of invasion, some kind of cellular damage. That usually happens in the distal bowel, in the colon and the large intestine, right? This will lead to dysentery, which we also call inflammatory diarrhea. A lot of you ask me the question, ma'am, what is the difference between dysentery and inflammatory diarrhea? Means the same thing. Inflammatory is basically telling you the process of inflammation which is leading to the symptom of blood in stool, which we call as dysentery. Okay. Over here in the stool examination, you will find polymorphonuclear leukocytes, means WBCs are going to be seen, and penetrating means now it is penetrated inside, which is your enteric fever or typhoid, which can be seen, right, where the actual symptom presented to you is fever. That is an important, a penetrating diarrhea is actually an important cause of bloodstream infection, systemic disease, not so much a important GI disease, right? We know the causes of acute gastroenteritis. This is actually a table from Anant Narayan. A lot of you must have seen this table, that there are bacterial, viral. Now this is what I want to address, okay, and parasitic. A lot of you tend to say that fungal candida albicans can lead to diarrheas because your book, a so-called standard book, says that. But please understand that fungi can only cause diarrheas in severely immunocompromised people, you know, AIDS, not even HIV positive, AIDS patients, cancer patients, heavily immunosuppressed people. And the diagnosis can only be made on biopsies, only on colonic biopsy. Okay, colonic biopsy. Never in a stool culture will you report candida. Never in a stool microscopy will you report candida. Okay, a stool sample showing candida on gram stain, showing candida on stool culture has absolutely no relevance, because this is an absolute commensal of the gut, of the skin, of the environment. So there is no way of finding out that the candida that we are seeing on gram stain or on culture is actually what we have picked from the environment or is the cause of diarrhea in this immunocompromised patient. So only and only if in a colonic biopsy inside the tissues you find yeast cells, only then can you say, and the patient is heavily immunosuppressed, only then can you say that this is a cause of diarrhea. I took a snapshot of this table and I brought it out because I wanted to clear this confusion. Rest viruses you all know, Rota, Adeno, Calci, Norwalk, etc. Parasites you all know, Entamoeba, Giardia, Balantidium coli, the coccidian parasites, and also some trematodes infections, right? This is just repeating what we know. Now, we have been able to establish up till now that in this patient, I need to go for lab diagnosis. So, for lab diagnosis, the first thing that we do is microscopy. In microscopy, if there is any ovicyst or parasite, we will do the microscopy. Oh, no ovicyst is going to be seen over here. What will I see? Pus cells and RBCs, which is going to tell me that this is an inflammatory dysentery diarrhea. Hanging drop Vibrio cholerae would show me what? Darting motility. Over here, I will tell you what I saw in my patient was non-motility. Non-motile. Okay, but see, whenever you are taking the stool sample, there will be a lot of gut commensals. So directly from the stool sample, if you are making a hanging drop, you will definitely see lots of motility, because there will be lots of bacteria, good bacteria, bad bacteria. So hanging drop directly from the stool sample only has the importance of whether there is darting motility present or not. Whether there is darting motility present or not. In my scenario, I am telling you no, there was no darting motility. Then gram stain, if you see any special type of curved bacilli, etc. No, I don't see. Zn staining, do I see any acid fast structures? No, I don't see any acid fast structures, right? This is what I am telling you up till now. Of course, we can't do electron microscopy for viruses. That is the most expensive test that you could ever do. That is definitely not done for routine diagnosis, right? So I am telling you that first I did microscopy and I found lots of pus cells and RBCs, and there was no darting motility, there was no acid fast structures, and there was no special gram stain structures present. So this tells me that we are probably now dealing with a normal gram negative bacteria, right? Because anyways, gram negative bacteria is also part of the gut flora. So whatever my organism is does not have any special shape or motility, right? So my causes of dysentery, what were my causes? I saw no ova cyst. So Entamoeba histolytica, probably not a cause. Vibrio parahemolyticus, Vibrio cholerae, probably not a cause. Now Campylobacter, probably, but I could have missed it also. So mostly I am getting cornered to either enterohemorrhagic E. coli or Shigella, but I cannot totally rule out Campylobacter Vibrio cholerae. So I need to now confirm it with a culture, right? What do we do with culture for stool? First of all, we do direct cultures on a selective media such as McConkey's agar. So either I will see lactose fermenter or a non-lactose fermenter. If I see many lactose fermenters on McConkey, I ignore it, because E. coli and enterobacterials are all a part of the gut flora. So if I am seeing that, no problem. I am telling you that I am seeing some non-lactose fermenters on McConkey, right? So now I need to be aware a little bit, because Vibrio is non-lactose fermenter, Campylobacter non-lactose fermenter, Shigella non-lactose fermenter, Salmonella non-lactose fermenter. Probably now my pathogen is what I am going to find. Of course, every time for stool you have to do enrichment. For every sample which is enriched with normal flora, you have to do enrichment, because you want to suppress the commensals and you want to promote the pathogens. That is what you want to do. So what do we use? Selenite F broth and alkaline peptone water. Alkaline peptone water for Vibrio cholerae and selenite F broth we use for Shigella and Salmonella. Then from this enrichment I will do some selective. Wilson Blair for Vibrio cholerae, TCBS for Vibrio cholerae, XLD and DCA, right? All of this we can ignore right now, because we are probably dealing with some bacterial cause over here. I am telling you, we got a non-motile gram-negative rods which are non-lactose fermenter on McConkey agar and pink colonies on XLD. You remember this was the XLD agar and this was the McConkey agar, and these are the pale non-lactose fermenter colonies. Yes, and on XLD you could either see yellow colonies or pink colonies. The pink colonies meant either it can be Salmonella or it can be Shigella right? The red colonies with pink colonies with black center was Salmonella typhi, and pink colonies without black center was Shigella. That is what I am seeing. This kind of looks like Shigella to me now. So how will you do the further lab diagnosis of this? So now you have probably narrowing it down to Shigella, because you have gotten non-lactose fermenters and pink colonies on XLD. What else do you want to do? Most importantly, you want to do serotyping. Yes, serotyping will tell me whether this is Shigella dysentery, Shigella flexneri, Shigella boydii, Shigella soniae. Yes, that is what is going to confirm my diagnosis of Shigella. This is what is going to confirm my diagnosis. So it can be Shigella dysentery type 1. Right, it can be Shigella flexneri, it can be Shigella boydii, it can be Shigella soniae. In India, most common is flexneri in India, so probably in this case it was Shigella flexneri which had caused dysentery in my patients. Okay, then are you going to do any further lab diagnosis other than serotyping? Not required. You can go for PCRs, etc. But serotyping is what is more or less going to confirm your diagnosis. Of course, you can go for biochemical tests, or you can do some MALDI-TOF, which is okay, MALDI-TOF will not tell you the difference between E. coli and Shigella. You can do Vitek 2. Okay, what did I say? No MALDI-TOF, because MALDI-TOF cannot differentiate between E. coli and Shigella. This is some high-end knowledge. You can ignore it, right? Now, the next question is treatment and prevention. Treatment here is very important. Of course, oral rehydration you are going to do. oral rehydration you are going to do. Will you give antibiotics? Will you give antibiotics? And prevention is supremely important. Why? You see, poor bichara friend also got admitted. Why did he get admitted? Shigella has a very, very low infective dose. Very, very low infective dose, you know. So, we have to remember that for prevention, Shigella has a low infective dose. How low? 10 to 100 bacilli is enough. Where for Salmonella and Vibrio you need 10 raised to power 8 bacteria. Here 10 individual bacteria is enough to cause infection in others. So you know what is the most common cause of acquiring Shigella infections? Most common cause is not food intake. Most common cause is actually contact. More so household contact. You know, it is most commonly acquired through touching of the doorknobs, handles, flushes. So what was the poor roommate doing? He was sharing a bathroom with his roommate, and the roommate was just shedding Shigella in the stool, and then that even 10 individual bacilli which can very, very easily contaminate the flush, the door, the handles, because the patient is sick, right? So the patient must not be very focused on hygiene at that time probably. So your door knobs, handles, that is why whenever you have any patients of dysentery, especially bacillary dysentery in your households, you should be very, very aware to prevent the other people. And you know what is the recommendation? What is the WHO recommendation? 32 hand washes per day. Can you believe that? 32 hand washes per day. So 32 you must definitely not be doing. So definitely much more frequent hand washing is what is needed by the contacts. So always remember, for dysentery, the most common cause of acquiring the disease is contact with a case, contact with a diseased person, and not so much from any food source, right? So any antibiotics would we give? Now the thing with dysentery, Campylobacter, etc. is that these are plasmid mediated drug resistance. So drug resistance is on an all-time high. Okay, so there is lots and lots of drug resistance which has been seen. So you have to give according to AST profile, AST result, right? So over here in further lab diagnosis, very, very important is antimicrobial susceptibility testing is a must in these cases, and depending upon which drugs the lab is saying that are susceptible and can be given, only those should be advised to these patients, because very, very quickly, because of plasmid mediated resistance, the bacteria are able to transfer drug resistance to the other fellow bacteria, and then treatment becomes even more problematic, right? This is a complications. Now since we're talking about Shigella, it is important to understand the complications, because you must have all heard of the Guillain-Barré syndrome in Maharashtra. Very, very recently it was seen. That was because many people were getting Campylobacter infections. They were self-limited infections, diarrhea was subsiding, people were fine, and after some time they all presented Guillain-Barré syndrome. Then complications such as Reiter syndrome. Yes, can't see, can't pee, can't climb a tree. So you get conjunctivitis, you get urethritis, and you get arthritis because of a diarrheal illness you had gotten in the past. So Shigella is a very important cause of Reiter syndrome. So reactive arthritis, which was formerly called as Reiter syndrome, Shigella, Salmonella, Campylobacter. This is actually a INICET question. This is actually an MCQ. So you have to remember the complications of Shigella. Bacteremia, since it is invasive, it is leading to inflammation and lots of tissue damage. It can go, if it enters inside the bloodstream, it can lead to bloodstream infections. Seizures, so that is called as Eric's phenomena. in Shigella, right? So it leads to meningoencephalitis kind of a symptom. It can also go to the brain. Then because of reactive arthritis we have just seen, and hemolytic uremic syndrome, HUS. Patient had diarrhea, diarrhea got fine. After that, patient presented with what? Thrombocytopenia, purpuric rash all over the body. Hemolytic uremic syndrome can be seen with Shiga like toxin producing bacteria. So it can either be Shigella or it can either be E. coli, enterohemorrhagic E. coli. They can all lead to HUS. So please also remember the complications. This becomes an important INICT level question. Complications of diarrheal illnesses. So with Shigella, the story does not end with a self-limiting dysentery in a patient. The story gets transferred to the household contacts because it is highly infectious, because infective dose is extremely low. The story gets further complicated by the complications such as Reiter syndrome, reactive arthritis, meningoencephalitis, and hemolytic uremic syndrome, HUS, the three very, very important complications of Shigella, right? So, of course, finally, you can reach out to me in any of my social media. Here is my YouTube, Instagram, and Telegram. You can contact me here. I always tell my students to stay in the game. Simply keep becoming a part of the discussion and stay in the game, right? So thank you so much, guys. That was all from me. If you have any more queries, then you can reach out to me on my social media, and I will be back with another interesting case series for you the next time. Until that time, take care. Good night. Bye-bye. Stop.